Native Americans continue to die at higher rates than other Americans in many categories of preventable illness. Will that continue? Changes in Native American health care tonight on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. I'm Dr. Deb Johnston, one of the Prairie Docs. The United States has a legal obligation to provide health care to American Indians, yet Native American communities face significant inequality in health care and health status compared to other U.S. populations. First, let's take a look at this week's Prairie Doc quiz question. The people of the Oyate Nation, or the Seven Council Fires, prefer those determinations because their enemies applied the following meaning to the name Sioux. Number 1, bat. Number 2, little snakes. Number 3, pig. Pick the best answer among those options. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of Dr. Holmes' book, The Picture of Health. Each of his essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your questions about Native American health care as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Mark Harlow, Chief Medical Officer with Oyate Health Center, Rapid City, and Jerilyn Church, CEO of the Great Plains Tribal Chairmen's Health Board. Welcome. It's so good to have you here with us today. And you guys had quite a trip to get here. My gosh, coming from Rapid, and you came from even further. So, did you have a good flight?
Yeah, we did.
Okay.
Yeah, I did.
She was meeting in Washington, D.C. today and changed her flight to come into Sioux Falls. I picked her up mid-afternoon and we drove up here, and here we are.
And we appreciate it very, very much.
Well, thank you for having us.
Thank you guys for
Good
being
to be
here. So, now did I say that correctly? Oyate?
Oyate.
Oyate. Okay. You even tried to coach me on that on the way in, and I didn't get it right. So I hope you guys are going to call in with some questions. We have some great experts here on a topic that's very, very important. So can you touch just a little bit on what the disparities are so that we can educate some of our viewers between Native American populations and the general South Dakota populations in overall health status, illness, death rates? I understand maternal mortality rates and premature birth and all kinds of those indicators of health are diverse in the Native American population.
Sure. Sadly, American Indians in the Great Plains in particular have some of the worst disparities compared to the larger population, but also compared to American Indians in other areas. I think that's a reflection of ongoing challenges in the Great Plains region. I think it's a reflection of healthcare delivery still being provided through a federal system that's antiquated and underfunded. We see life expectancies for women in the mid-50s, and for men it's even younger. So significant difference from the larger population.
That's a very difficult thing, and it has to be very difficult as a clinician, as a provider, to see people and know that their futures are much grimmer than they would be under other circumstances.
Very much so. Years ago, when I was returning from a trip to Haiti, when I returned home, there was a newspaper article about Pine Ridge being the poorest county in the United States. And for me, that was an epiphany that I don't need to travel far to find needy people. I have plenty of people right here where I live that are in need of quality health care. So at that point, I decided to direct my efforts to go to Pine Ridge, and did for many years. And then recently, I've joined Jerilyn and her team to expand services for all of our tribes in western South Dakota, the Oglala Sioux tribe, Cheyenne River tribe, and the Rosebud tribe, as well as the unaffiliated tribal members. And I couldn't be more excited about the opportunities that are in front of us.
Can you tell us a little about this new program that your organization is doing to try to address these issues and improve the health care of this population?
Sure. So there is a federal law called Public Law 93-638 that allows tribes to take over management of their own healthcare system. So it essentially takes the funding that IHS, Indian Health Service, currently has, puts it in the hands of a tribe or a tribal organization such as the Great Plains Tribal Chairmen's Health Board, and allows self-determination, allows the tribes through whatever vehicle that they see fit to use those funds in a way that better meet the needs of the community. And so in the uniqueness of Rapid City is that, one, it's a facility that's not on a reservation. Two, it's a facility that is, the shareholders are more than one tribe. So the tribes began to look at self-determination as a means to address the number of failures that were coming to light. First in 2010 through Senator Dorgan's report, and then around 2015 there was a realization that things weren't getting better. In fact, they were getting worse. In Winnebago, which is in Nebraska, but in our catchment area, their hospital lost their ability to bill Medicaid because of problems within their system. Then we began to hear about problems in Rosebud, Pine Ridge, and the fourth facility was Rapid City Service Unit. And it was at that point that tribal leaders looked to the Great Plains Tribal Chairmen's Health Board to look into the feasibility of pursuing this law, Public Law 93-638, as a solution.
And I think we have a graphic up that shows the area that your organization is working with, which is, we can see, is quite a large area.
18 tribes that reside in the states of North Dakota, South Dakota, Nebraska, and then we have one member tribe in Iowa. So our service area mirrors the Indian Health Service.
Okay, and how many people are included in that?
About 170,000 American Indians across the 4 states.
That's a lot of people.
It is.
So, one of the things that you had alluded to in our conversation earlier that I think I had not really been fully aware of is the federal obligation to provide health care to Native American individuals. Can you fill us in a little bit on how that came to be? I'm sure I'm not the only one in the audience that does not understand that history.
Sure. Well, one thing that's really unique when it comes to health care for American Indians is that we are the only population that the federal government has a legal obligation to provide health care to, and it is a result of treaties that were made with the federal government, and in particular in our area, the Fort Laramie Treaty. Our ancestors paid for this health care, education, and other services in exchange for the land that we live on now. They paid for it through their lives, And so that obligation, that treaty and trust obligation, is taken very, very seriously by our tribes, by our tribal leadership. We were born and raised to recognize that these treaties are supreme to our tribe's survival. And so we take that obligation very, very seriously.
It's, I think, a very important part of history and understanding how we came to be where we are now and why there is not just a need but an obligation to improve the situation for the tribes. And also I think it's important to point out that you know, a rising ocean raises all boats. So if we improve the health care of one segment of the population, that spills over and improves the general health of all peoples, and that's an important thing to recognize. So looks like we have some questions here. So someone from Fort Thomas asks, why doesn't the federal government do anything to alleviate some hardship on the Sioux Indian reservations? I'm sorry, on the Oyate. No, I still said it wrong. Oyate. So I think that's a very good question, and probably a question that many people have asked over the years.
Sure. And we continue to ask. So one of the things that's disheartening is that when you look at the Indian Health Service budget, overall it is only about 50% of the need. We've seen a huge deterioration in the quality of care through Indian Health Service, a huge deterioration in infrastructure, capacity, and overall health care. And it's because of the chronic underfunding. The challenge for tribes is that we are the smallest segment of the population. When you look at the overall population of this country, American Indians make up less than 2%. Not a very strong lobbying bloc, not a very strong voting bloc. Only 30 states have tribes that reside within their boundaries. So to put forward the needs of tribes in a way that is effective is a heavy lift, and it largely requires our legislative leaders to take pause and listen to issues that may not directly impact their voting bloc and rely largely on their conscience.
One of the things in that conversation we had before the show that was extremely surprising to me was when you had given us the data about the funding per person that Indian Health Service receives as opposed to Medicare, Medicaid, other common programs. And I think our viewers would probably be very startled to hear that too.
Well, it's the only time in my 34 years in medicine I've had to deal with a capitated program, which is to say I have a set sum of money every day. So it gives me a small box every day into which I am supposed to squeeze all the care that we need. Instead of saying, here's how much care we need to fit our payment model around that. So every day when I sit down with our PRC committee, I have between 50 and 120 patient records. I go through each one and prioritize them on a scale of 1 through 5. And then when I've done that, we get out the calculator. And when we run out of money, we run out of care. And the remaining patients get deferral or denial letters. And it's the only place in medicine that I've ever seen that take place. If I were to say that's what's happening with Medicare or Medicaid or veterans or CHIP or any other subset of Americans, it would be an outrage. And it's just profoundly wrong that this is the status quo and this is what's been accepted. And when you look at the number of dollars allocated with my budget and as many patients as we serve, It's approximately $400 allocated per year per patient, and we all know that $400 doesn't go very far with medical bills, compared to Medicare, which is approximately $12,000 per year, Medicaid, which is approximately $8,000 per year, veterans approximately $9,000 per year, and we are down here at $400 a year. So when people in federal agencies say IHS has enough money, I will tell you that at the critical point of delivery of care, I don't have enough money, and it's a daily struggle. We squeeze every penny out of every dollar we have in PRC every day, but it still leaves us with people without coverage.
And as a primary care provider, one of the things that I know is that preventative services fall to the bottom of the list. If I have someone who has a heart attack and needs a bypass surgery, obviously that's a much higher urgency than somebody else getting their flu shot, but we also know that prevention is very cost effective in the long run.
Great.
But it falls down on that list of 1 to 5 in urgency, and so it gets very hard when you don't have enough funding to meet all of those needs to include that prevention. You end up having the more expensive types of care. So that's a very important point to remember. So here's another excellent question that kind of falls into the same thing. Why is Indian Health so underfunded?
It's a good question. I ask that frequently. I think until it becomes a priority for our lawmakers, and becomes a priority for our lawmakers, in particular in the states that where tribes exist, we're not going to see any changes. We have been asking for adequate funding for decades, and it hasn't happened. And that's one of the reasons why tribes are looking at self-determination as a solution, as part of the solution. It's not all of the solution, but it's a part of the solution. We're able to take the funding that Indian Health Service has, and rather than have that care delivered through a federal entity that cannot apply for grants, that cannot do fundraising to foundations and other donors, the money that exists for PRC that Dr. Harlow was talking about will remain the same. As a 638 program, we can apply for other funding, we can fundraise, we can look at how to take that same pot of money and perhaps, instead of paying dollar for care that's referred out, we can take a portion of that money and sponsor insurance plans for some of our relatives who come into Oyate Health Center so that they can get coverage. So we can do innovative things to try to make those dollars go a little bit further. I will still advocate strongly for additional funding. I think the rates of inequity and disparity speak for itself. I think that by our organization running a program itself, we can speak directly to those shortfalls and be able to share transparently with our lawmakers, this is the reality of what we have to work with and how far it goes.
I think that will be a good thing to continue talking about in a few minutes. The Wakini Initiative is helping shape the future of some American Indian college students, thanks in part to SDSU President Barry Dunn, an enrolled member of the Rosebud Sioux tribe.
So when we started the Wakini Initiative, we pledged to, number one, make a land acknowledgement about the land and its relationship to SDSU, which we've done. We pledged to raise scholarship dollars, pledged to build a new American Indian Student Center in the heart of campus. We've done that. And we pledged to change South Dakota State so that we can serve those young people more appropriately. Key to the WAKINI initiative is the acknowledgement that with statehood in 1889, South Dakota State University received land-grant status in the Enabling Act of Statehood. And with that came 120,000 acres of land, either rent from the land, or if the land was sold, the assets were put into the School and Public Lands Trust, and then we received the earnings from them. What we're doing is taking the resources that we receive every year from that land grant, and we're dedicating those resources to the heirs from whom the land was taken so long ago. They come from very impoverished communities, very difficult communities, from multiple social perspectives. And so but we are holding true to that commitment, and we're finding the scholarship dollars and the programming dollars and the support dollars to help them succeed when they come to South Dakota State and graduate. I believe that the WAKINI initiative can dramatically improve healthcare for American Indians in South Dakota. And as an example, I was asked by an Associated Press reporter about how I would measure success if and when WAKINI was successful. And I turned back to my home country of the Rosebud Reservation, and who are suffering from real troubles with Indian Health Service and the hospital there in Rosebud. And I described it when the doctors who are serving Rosebud's IHS hospital aren't flown in from Los Angeles, but they're tribal members who went to SDSU in pre-med and then went to USD and got an education, and they went back and they're serving the Rosebud. I said that we'd have success when the pharmacist in that hospital was a pharmacist who grew up on the Rosebud, but who graduated from our pharmacy program. It's not so much about SDSU, but we have the academic programs to help healthcare on the reservation. We have the solution. We just need to make it a reality.
This is your program, and your questions are key to the direction of our discussion. Call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. We were just having a little bit of a conversation here during the credits about some of the innovative things that you're doing in your new clinic facility to integrate more allied health and more supportive services. Can you tell us a little bit about that?
We have taken a page from the book of the South Central Foundation in Alaska, which has really blazed a trail for us on how to provide primary care in an integrated model. And to that point, we are building teams. We have 3 teams now at Oyate. And all 3 teams have a pharmacist embedded in the program. They have a behavioral health specialist embedded and a benefits specialist. So the patient comes to their room. They are then seen by the nurse for vitals and any other processes that need to take place. And then their provider comes in. And then if there are questions about their medications, the pharmacist comes in, reconciles meds, checks the PDMP, the drug monitoring program, to make sure that we don't have duplication of medications. And then if there are questions about benefits, or if there's a perceived need for behavioral health, then we have that all brought to the patient in their room. So they come to their room, and all of these services then come to them instead of having to go to multiple sites and multiple buildings or take your prescription to a faraway pharmacy. We're trying to integrate it and make it as easy and as patient-friendly as possible. And that model has succeeded wonderfully well in the Alaskan experience.
I actually have a colleague who does some hospitalist work for us here, and she actually participates in that program and has a lot of really good things to say about it, and how much more effective and efficient that care delivery is for those patients. And even for her as a hospitalist, she sees the downstream effects of being able to make those handoffs and know that things will happen for that person. So I think that's really wonderful.
And our providers have really appreciated having a pharmacist readily available for medication questions, and again, to reconcile the med list so that we don't end up with the patient having polypharmacy for multiple providers that really isn't healthy for the patient. So.
And a lot of drug interactions, and maybe this medicine would be a little bit better for this reason. We've added a pharmacist to our clinic, and it's been very helpful. So I think it will be a great thing for your population as well. And I think that it rolls into another question that came in here that I think is partially addressed by that. Somebody from Fort Thompson asking, what is IHS and of course your organization doing to inform people about drugs and addiction?
We recently did a needs assessment in the Rapid City area, and to get a sense of what the community sees as priorities. There's needs all across the spectrum, but we need to start where the most pressing needs are. And behavioral health and substance use disorder support services was at the very top of that list. One of the things that by integrating behavioral health specialists into the clinic, oftentimes it's the primary care physician that sees the first signs of mental health distress or addiction, because addiction takes a toll on the body and it presents itself in the exam room. We're hoping that by addressing those needs very, very early on, or assessing that there's a need very, very early on, that there's a greater likelihood of that relative who's come in to be open to getting services that are needed. The challenge is that there are very few mental health facilities, there are very few substance use disorder facilities that can address the complicated needs that are presenting in our communities, both in terms of opioid addiction, meth addiction. So there's more that needs to be done to build capacity within our state and within our tribal and IHS facilities to meet the demand. But by intervening earlier and having conversations in the safety and privacy of an exam room, we can begin addressing those problems earlier on.
I think it also helps with the stigma when we integrate it with medical care, because it's a very false distinction that mental health and physical health are separate things. They really very, very much influence each other. So it's a really wonderful thing to have that behavioral health support there at the point of care.
We're very much rethinking how we approach mental illness. If we have someone who has a daily physiologic need for insulin, we don't call that person an insulin addict, we call them a diabetic. If they have a daily physiologic need for an opioid or alcohol, we need to approach it in a similar fashion and realize that we have to address the physiology from a medical standpoint as well as the behavioral component. And it's well established that if you address them both, your success rates are much higher. And we do have resources in Rapid City that we have available. We're working with Project Recovery, which is the opioid use disorder program run by Steve Tamang and his team, and they have offered to come and do a half day a week with us over at Oyate. And then of course the county has the Care Campus, which has been very instrumental in addressing these needs as well. They have 83 beds available, 40 for detox approximately, as well as safe beds and crisis care beds. So the Rapid City community is reaching out to address these behavioral health needs in a very proactive way. And Monument Health, Monument Mayo Health has also stepped up with services as needed. So we consider them a great partner, as well as the private sector physicians in town that we are affiliated with.
And I think that that's a very important thing, that these needs affect the entire community. It's not limited to the Native population. The Native population again, may have more difficulty accessing, but it affects the entire community, it affects the entire state, and it's a very important thing to address. You mentioned diabetes, and we had a question about, is there a difference between biracial and full-blood Native Americans in terms of cancer rate and diabetes rates, and also between men and women in the Native population? Do you see differences? Are they similar to the differences that we see in the non-Native population, or what do you see in terms of statistics for demographics? And
I don't think there's a distinction between someone that's full-blood or half, or some other percentage of American Indian, but there is a higher propensity for diabetes with American Indian population in general. There's lots of theories of why that is. I don't think anybody really knows, but it has been on the rise. I remember my grandmother, she didn't have diabetes. She wasn't overweight. She was very healthy, and she lived a long, healthy life. My aunts, on the other hand, and my mother, all have had diabetes. Two of my aunts are no longer here. My mother's still here. My sisters, I have 3 sisters. All 3 of them have diabetes. I don't have diabetes. I don't know why generationally it seems to have gotten worse. I think there might be, one of the theories is that we are further removed from our traditional way of eating. I was raised by my grandparents, so I ate wild game until I went to school. So our ancestors ate foods that were indigenous to the land that we're on. They were more active. They ate meats that they hunted, and now we have an American diet that is less than ideal, and
for all of us.
For all of us, and contributes to obesity and larger amounts of sugar. So I think there might be
products.
Yeah, there may be a correlation there.
A woman from Spearfish asks, what would happen if a president came in with Medicare for all, and how would that affect Native peoples?
The same way it would affect non-Native peoples. People would have access to health care that they need. We'd have a healthier nation. We would we would see mortality rates improve, and I think we would be overall much healthier.
And I think this goes to what you were talking about before, about the capitation and having enough money to provide care to your patients.
For all the years that I was at Pine Ridge, when I would see a patient and recommend a surgical procedure to improve their quality of life, it would go to Contract Health. And when the denial came out, I could always blame it on those mean people behind the door. Now I'm the mean guy behind the door with the pen in my hand, making the decisions on how to ration health care. That's the word no one wants to talk about, but it is rationing, and that's the reality of Indian healthcare every day. So by having a program that eliminates the need for rationing, then people will get their care without fear of going into financial destitution by virtue of their healthcare needs. That is something that we need to address as a society, and haven't done so effectively to this point.
And I see that even my own practice, which has the rationing where, well, do you have insurance? Will your insurance cover this? And I see lots of people who wait until they're on Medicare to get their hip replacement or whatever else it is that they desperately need, and it interferes with their life in the meantime. They can't exercise to control their diabetes. They can't do whatever it is that they need to do because they can't get that first step done. So here's a related question, I think, that is important to ask. Do Native Americans qualify for Medicaid?
Some do. If they meet the requirements for Medicaid, then they do qualify. What we have discovered at the Oyate Health Center is nearly 60% of our relatives that come for care are uninsured. What we've seen with our tribes in North Dakota, north of us, who expanded Medicaid, is that these PRC dollars that Dr. Harlow was talking about go a lot further. So Indian Health Service has this tiered system, and if they for level 1 care, it's the most extreme care, life or limb, and then it's the level of care is graded by level 2, level 3, level 4. In North Dakota and other states where tribes reside, where they've expanded Medicaid, the PRC, they're not running out of PRC dollars because more people are covered by insurance. So the purchase and referred care is the payer of last resort. That funding is a payer of last resort, seeing a huge difference in access to care between the two.
And I think that that's true for everybody in the state, not just for Native American individuals, but for all residents of the state. So
36 states have already expanded
Medicare.
Medicaid.
In Lakota, the word Wokini means new life or a new beginning. The Wokini Initiative at SDSU seeks to mend the often tragic relationship with our state's 9 tribal nations by providing better academic and financial support to American Indian students.
So the Wokini Initiative has ultimately become SDSU's framework for supporting American Indian students. And so part of that framework is scholarships. So we are able to offer $5,000 a year scholarships, renewable for up to 5 years for incoming freshmen. We also have 3-year scholarships, also $5,000 a year for transfer students. If students get a 2-year degree at a tribal college and they'd like to come to SDSU to complete their 4-year degree, we have scholarships for those students, or if they completed a 4-year degree at their tribal college and would like to come to SDSU for a master's degree, same 3 years, $5,000 a year. Future goal, one that we're working on now, we were able to secure a grant and we're developing professional development for our staff and faculty to better educate them on American Indian history, government, culture, tribal sovereignty, and that education is part of increasing the capacity for workforce development. The American Indian Student Center then really works with the cohort of Wokini scholars, and so again, the huge impact that we've seen is just the first cohort of Wokini scholars had an 80% retention rate, and that is again, it's only been that 1 year, but that is phenomenal. And we've also had a slight increase in our American Indian student enrollment at SDSU, but considering our total enrollment has gone, really low and gone down, being able to say that our American Indian student enrollment is going up during this kind of time of enrollment crisis, that's been a huge impact as well. With the Wokini Initiative, we've tried to build better partnerships with our West River College of Nursing. They have NANIC, and so Bev Warren works with the Native students as well as Valerie Big Eagle. And again, trying to partner better, and we really want to support that program. They do a great job of recruiting Natives into the nursing program there in Rapid City, and then they do a tremendous job of supporting those students and providing for their needs. So a lot of the Native nursing students in the Rapid City area do live in tribal communities close to Rapid City, and so it's a great partnership. So they're able to either drive or be near their home, and then a lot of them go back and work in their tribal communities.
Welcome back to On Call with the Prairie Doc. We're having a great conversation now about healthcare on the reservations here and for Native American populations here in the state of South Dakota. And here was an interesting question from a gentleman in Rosebud asking, how does IHS go about paying for hospital bills not on the reservation, not through the IHS system?
So Indian Health Service covers payments for tribal members that live within a what they call a CHSDA, Contract Health Service Delivery Area. And if you don't live within that, what they call CHSDA, you're not eligible for purchase and referred care. And that's a constant source of tension between our non-Native providers and Indian Health Service in the state of South Dakota. In the Indian Healthcare Improvement Act, which was embedded within the ACA, there was a change to that CHSDA that allows North Dakota and South Dakota to be one CHSDA area, which means anyone that was living within North Dakota and South Dakota could go to any IHS facility across those two states and be eligible for PRC. Indian Health Service has not implemented that law. It's in law, but they haven't adopted it as a policy. Part of the reason they haven't done that is because there would be additional funding that's required. Right now, if you don't live in the contract service delivery area, so for example, in Rapid City at the Oyate Health Center, you have to live within Pennington County. The downside of that is that we have American Indians, we have relatives that live in Black Hawk, we have relatives that live in Hermosa, in areas that are not within Pennington County. They live in Meade County. They're not eligible for purchase and referred care. So it creates a tension because there's an expectation or a perception by many of our larger healthcare providers, the big three in South Dakota, that Indian Health Service is responsible for paying for care for any American Indian or IHS eligible Indian, and that simply isn't the case.
Is it true?
Yeah.
Okay. We have a caller from Sioux Falls wanting to know that the IHS owes Bennett County a significant amount of money because the federal government is not reimbursing the way they are supposed to. What can we do as a state and the Sioux Nation to get the federal government to pay what they owe?
Well, there's a couple of things that could happen. One, they could increase the funding so that we are funded at, Indian Health Service is funded at 100% of need. Another option is to expand Medicaid. So I often say that the federal and trust responsibility to deliver health care, to provide health care is not, our treaties are not with Indian Health Service. Our treaties are with the federal government. So there's many other agencies within the umbrella of HHS that if they were fully funded or funded to provide services to tribes, that would increase access, that would increase funding.
I think the bottom line is write and call your legislatures.
Absolutely.
Call Rounds, call Thune, call Dusty Johnson, let them know that we care about this issue. Another individual asked about the suicide rate. What ideas do we have to reduce the suicide rate on the reservations and among the Native American population?
I think that we have seen some of the highest suicide ideation attempts and completions in the Great Plains and many other areas. Until our young people have a sense of hope, until we can address other social determinants of health, there's always going to be that challenge of a sense that there's something more.
I think that's such an important thing for all peoples. We need hope, and people need to know that there's a better possibility for life.
Absolutely.
I think that's an important thing for all populations. So, we have a question about what would you do if you had the resources to cut down on infant mortality rates?
Well, we would expand our obstetric services and address the prenatal issues that we do have control over. As you know, there are always uncontrollable variables in medicine, and there are controllables. And so we must control those which we can, and that includes addressing maternal health, maternal alcohol consumption, tobacco intake, all of those things that are controllable. And
safer sleep practices.
And we need to have a program that reaches out to new moms and educates them in these important things. And we have had conversations to discuss the expansion of our services. We've had conversations. We have Native Women's Health on campus at Susan. We're looking to collaborate with others in the community to expand our services and improve our care. There are no boundaries on what we're trying to dream of here. We are looking to serve everyone as fully as we possibly can.
Need the funding to make it happen.
And we do have great support and partners in our community. Many of my friends and colleagues over the nearly 30 years I've been there have reached out and said, how can we help?
It's a community effort.
I'm so pleased that I'm getting that kind of response.
And now for the winner of tonight's Prairie Doc quiz question. The people of the Oyate Nation are the Oyate. You'd hope that I'd get it right by now. Oh my goodness. Or the 7 council fires prefer those determinations because their enemies applied the following meaning to the name Sioux. This is their enemy's name for them. Pick the best answer among these options. Number 1, bat. Number 2, little snakes. Number 3, pig. And the answer is number 2, little snakes, from a French transcription of a spiteful nickname given to them by their enemies, the Ojibwe. It was George Hale from Elkton, South Dakota, who answered the question correctly. Thank you, George, for participating, and a book will be in the mail to you soon. As you might know, Dr. Holm is living with pancreatic cancer. While he is not quitting, he wants you to know that if or when he is no longer available due to illness or death, he and his wife Joni have made plans so that the mission and work of the Prairie Doc will continue. And here's more.
Throughout my 40-plus years in medicine, I've advocated for the team-based approach to working with my peers to address the needs of our patients.
The same power of collaboration has proven successful during the 18-year history of Prairie Doc TV, radio, and newspaper.
Our Prairie Doc mission is to enhance health and diminish suffering by sharing honest, science-based information with you in a respectful and compassionate manner.
We'd like to introduce our team of Prairie Docs, each committed to this mission.
Family physicians Andrew Ellsworth, Deb Johnston, and Jill Cruz, along with internist Kelly Evans, all of Brookings, South Dakota.
These volunteer physicians and many others have in the past and will in the future serve as authors of Prairie Doc newspaper columns and host our TV and radio programs.
Please join me with a thankful heart as I hold high the Prairie Doc torch with these talented and caring individuals. Eventually, I will pass the torch on to them as they are truly Prairie Docs, one and all.
Thank you.
As I was researching the history of Native American healthcare, I took note of the various terms used early on by the indigenous people to describe European immigrants. Initially, the references had to do with skin color. Several tribes labeled Europeans as white-skinned or yellow-hided. Some tribes still use the term umsawa, meaning bleached wood. Other tribes describe Europeans as hairy-mouthed, or hair faces, or dog faces, referring to the facial hair on European men. Ears were also important in naming. One tribe characterized the immigrants as ears sticking out because they didn't have long hair covering their ears, as did Native Americans. Some say that the ear label referred to that tribe's word meaning for donkey or mule, though. As time went on, Native Americans began to describe Europeans based not only on how they looked, but on how they behaved. A Lakota word for Europeans is wasichu, which means taker of the fat, or a greedy individual. Recognizing the transgressions over the last centuries, I can't blame the Lakota for choosing the label wasichu. These Native American words reflect the impact of two cultural worlds colliding and reveal a disharmony resulting from the loss of access to traditional hunting and farming lands, the loss of family and language as children were shipped to boarding schools, the loss of self-respect with isolation on the reservation, and much more. The result of all this has been decades of health disparities. For example, American Indians are 50% more likely than white people to have a substance abuse disorder, 60% more likely to commit suicide, twice as likely to smoke cigarettes or to die of childbirth, 3 times more likely to die from diabetes, and 5 times more likely to die of tuberculosis. But change is a-coming. Revered Ogallala Lakota mystic and medicine man Black Elk prophesies that with the 7th generation following the tragic Wounded Knee Massacre of 1890, Native American people would begin to recover from the historical trauma experienced since the collision of these cultures in the mid-19th century. From 1890 to 2020, that's 130 years. Divide that number by 7, and right now you have 19-year-olds who constitute that 7th generation. It's time for those of us with ears sticking out and those without, people of all skin colors and cultures, to create an environment that allows all people to come out of poverty and to help make positive changes in Native American health care.
A big thank you to our guests, Jerilyn and Mark, for joining us. And that does it for tonight. From all of us here on Call with the Prairie Doc, until next time, stay healthy out there, people.
The physical tolls of injury or aging are obvious, but what is the impact of Parkinson's or other dementia-type afflictions when our brain starts to fail? Next time on Call with the Prairie Doc.
All of us want our family, neighbors, and friends to have the ability to make appropriate decisions about their health care. To do so, they need access to information from reliable sources like Dr. Holm and his guest physicians. Hello, I'm Stephanie Herseth-Sandlin, and I serve on the volunteer board of directors of the Healing Words Foundation, a 501c3 organization established to support the work of the Prairie Docs. With your charitable donation, you can help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. This mission is so very important to rural communities and residents in particular across South Dakota and neighboring states. Please consider a personal or corporate gift. Just go to prairiedoc.org to find more information on how you can help. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions, South Dakota Foundation for Medical Care, Brookings Health System, Ophthalmology Limited, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Urology Specialists, Brown Clinic, American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians, Black Hills Medical Society, Aberdeen District Medical Society, Flandreau Madison Brookings District Medical Society, Sioux Falls District Medical Society, Yankton District Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care, Sanford Clinic Community Services Committee, Aberdeen Asthma and Allergy, and Swiftel Communications.